Hello, my name is Margie Dean. I'm a practical nursing instructor at Meridian Community College, and today I want to demonstrate how to give a bolus tube feeding. Gavage is what you may be accustomed to hearing. So this Gavage is an intermittent bolus feeding. The first thing we need to do is look at the facility's protocol and see about the frequency and the orders, and we're going to look at a set of orders here in just 1 second. If this is the first time that the feeding tube has been placed, then an x-ray would be done to make sure of proper placement. If it is an established feeding tube, then we're going to have to do a few things to check to make sure that it's in the correct place, and look at the facility, because the facility may have something specific they like to use as well. So we're going to look at the physician's order for the type of feeding. And I'm looking at orders here for this particular patient. And this patient is Lucy Bird. She has no known allergies. And the orders say Glytrol 250 milliliters QID per peg tube. And Glytrol is the name of the feeding. The amount is 250 milliliters, and it says it actually here on the container. The physician has ordered that amount as well. He has said QID, which means 4 times a day she's to get this. The solution and strength is actually what the complete nutrition is itself, okay? So in order to prepare for the feeding according to the physician's order, there are some things we need to get together as far as our equipment. So in assembling the equipment, you're going to have a stethoscope so that we can assess bowel sounds. We're going to have, of course, the feeding. You're going to need a cup that will hold the flush water, the amount that you need before and after the feeding. I always bring an extra cup just in case I want to pour the feeding in it. It's a little easier to control when you pour it in the syringe by using a cup. You're going to need a 60 milliliter catheter tip syringe, and it will be marked with 60 milliliters on the syringe. It actually has a cap that comes off of it. The syringes are changed every 24 hours at a facility. They would be marked with the date and the time that they were put in the patient's room, and they're discarded after 24 hours. But they're used throughout that 24-hour period. Okay, and I always bring a towel to protect the bed linen and the area around the patient. Of course, then I have my gloves. Okay, so now, if for some reason you need something larger, like an emesis basin, you could actually bring that as well if you want to put the gastric contents into the emesis basin. So as far as assembling equipment, we have all of that. You want to make sure that your container, your Glytrol solution, is still in date, so you should look at the expiration date on it. It says shake well, so you want to make sure that you shake it very well. A lot of times these are sitting on the shelf, so you want to wipe it off with either alcohol prep, or you could just use some water and a paper towel to cleanse off the dust that's on it, because it'll have a top that pulls off. I don't open this until I make sure that I can give it, because I do not want to waste it. Okay, so I've checked the date, I've shook it well. Then you're going to go in and you're going to prepare your patient. So when you come into the room, you want to make sure that you actually have introduced yourself to the patient. Good morning, my name is Margie Dean. I'm your nurse today. How are you doing? Are you having any problems? If they can speak to you, that's fine. Otherwise, you're going to ask them to state their name, their full name, and their date of birth, and look at their armband. Just don't say it without looking at their armband. If they cannot speak, you may have to come up with another form of identification, and in some extended care facilities, they have pictures of the patients. So I've identified the patient ×2. I'm going to wash my hands. And the next thing I'm going to do is assess the abdomen. And remember, there are 4 things that we have to assess when we're looking at the abdomen. Okay, so what I'm going to do is just pull the covers down. I want to maintain privacy. And if I'm going to assess the abdomen, the first thing I do is inspect. So I look to see if it is distended or not distended, and it is not distended. Then I'm going to listen. And I start in the right lower quadrant first. You listen. You're listening for the gurgling bowel sounds. Then you move up to the right upper. Then you go over to left upper and left lower. So bowel sounds are present in all 4 quadrants. Let me say that the head of the bed should be flat unless for some reason it is contraindicated because of feedings that you cannot elevate the head, lower the bed. So let the head down before you do the abdomen, okay? That is the best way to actually listen. So you're going to look, listen. Now we're going to palpate. And what we're doing, we're lightly palpating just to see if we can feel any hardness, seeing if it feels soft. And you can look at the patient as you're actually going around to see if they're grimacing, if they cannot speak. But you ask them, is this tender? Let me know if any place feels tender. So abdomen is not distended. Bowel sounds are present in all 4 quadrants. It is soft and patient states non-tender. Okay, so we have assessed the abdomen. So the next thing that we want to do is we actually want to raise the head of the bed back up, okay, because when we give a feeding, we do not want the patient to be flat. So I'm going to raise the head of the bed up, and I've lowered the side rail to make it easier for me to actually work. And we let it up to 30 degrees. A lot of your beds actually already have the marking that you can go by that. If it does not, you want to make sure that the mattress is right at the top of the headboard, okay? So I'm going to put on my gloves. And when we put on gloves, we call it don, D-O-N, don gloves. When we take them off, we call it doff, D-O-F-F. So I'm donning on my clean gloves. I'm going to actually put this towel here just to keep things clean. It can get just a little bit spillage or messy. Okay, so this is actually going into the stomach, directly into it. You're going to have a peg tube, and you're going to have a lumen. These are lumens. Lumen just to blow up a balloon that's on the inside. And we have got a lumen that you'll open up to aspirate gastric contents and to give the feeding. All right, so the next thing we want to do is we want to actually check placement. So in checking placement, we're going to aspirate the stomach contents, okay? So I have my syringe. Now, if I'm going to take the cap off of here, I need to clamp it so that it doesn't get any type of air into the stomach that we don't want in there. So I'm going to uncap it. I'm going to attach my syringe, and I'm going to aspirate. You have to unkink it. Aspirate means to pull back. So when you're pulling back, if you meet resistance, that means that the tube could be against the lining of the stomach on the inside, okay? So what I do is I kink it. I put about 15 milliliters of air. It says 10 to 20 on your paper. Now what I'm going to do is actually put a little air in there to move the tubing away. that opening away from the stomach. Okay, hopefully that helped. So we go to aspirate, pull back. Oh yeah, it did help. Now I'm getting about 20 milliliters of gastric contents. You have to give that gastric contents back to the patient. So you slowly insert it. This is the only time you'll use a plunger when you're giving a feeding. We're inserting the contents we withdrew. Those contents have electrolytes in it, and we don't want to deplete that patient's electrolytes. If for some reason you are aspirating and you draw back a syringe full, I'm capping it back off so I can talk to you. If you draw back a syringe full, you're going to have to continue because you do not know how much more there is. So you're going to want to take and put this in a container. You're going to go back again, aspirate, and your instructions say, and your textbook says, if you get back more than 250 milliliters of gastric contents, you're to hold the feeding. That means that the stomach already has 250 milliliters in it. And if you go to put another 250 milliliters on top of that, they could risk aspiration. Okay, it's like your gas tank in your car. When you fill it up with gas, if it's too full, it runs out. In this case, if the patient's stomach is too full, the only place it can go is back up the esophagus. And if it travels back up the esophagus, it could spill over into the lungs and cause aspiration. They could end up with pneumonia and other complications. Okay, so we have actually aspirated the gastric contents. We got back 20 milliliters, and we returned it back to the patient. So now I have to prepare to give my feeding. So I take out the plunger. All you have to do is remove it. Okay. I'm going to keep it safe so it doesn't roll off the table and put it back in its package. Because bolus means gravity, and we're doing it by gravity in this case, and we don't want to force it in, okay? Forcing it in could cause the same situation of aspiration. That's the reason we have the head of the bed up, is so they don't aspirate. So now we're going to kink it. Don't unkink it, because remember, I don't have a plunger in here. And if I don't have a plunger in here, that means air is sitting in that syringe. I have the numbers facing me so that I can read them. And the physician's order asks to flush it with 30 milliliters of water. We do not use cold water because we don't want to cramp the patient's stomach. We use tepid water, which is like lukewarm warm water. So I pour in 30 milliliters and I watch it till it gets to my 30 milliliter mark. And then I slowly let it go in. Water will go faster. Once it has reached right here in the neck, in this area, I clamp it back off. I can still see just a little bit of water right there. Then I'm going to take my feeding. And like I said, you could pour the feeding from here, or you could pour it into a cup. Remember, I did not open it until I made sure I could give the feeding. So when I realized I could give it, I opened it. I'm putting it in a cup. And I'm going to put it in. Now that's 250 milliliters. If I filled this syringe all the way to the top, 60, we're going more than 4 times. So this takes a little bit of time, okay? So you pour it in. I do not advise you to fill the syringe all the way to the top, because then it gets top heavy and it wants to spill out, okay? So I put 30 to 40 milliliters in it. Let it go in by gravity, okay? Before it completely gets out of this neck, I put more in. And I do that until all of the feeding is gone. Now the last thing I have to do is flush it again. We want to get all of this milk out. As you know, it looks just like milk. So I'm going to put 30 milliliters of water in. And then I'm going to let it run completely through. It has to come out of here, because when you get ready to separate this, it's going to spill if you have any in the syringe. So when the water's gone all the way through the tubing, I kink it and I clamp it. Okay. So you would end up having to clean this out, dry it out, and put it back up for the next feeding. It is also used to give medications as well, so you have to make sure it's kept clean. So we have put the flush in, which was 30 milliliters before. We gave 250 milliliters of glytrol, which is what the physician had ordered. And then we flushed it with 30 milliliters of water afterwards. And you can always look at the patient and ask them, are you okay? Do you feel too full? And making sure that they tolerated it well. Once you have finished the feeding, we always leave the head of the bed up 30 degrees, at least 30 degrees, to make sure that they don't have any possible chance of aspiration. And then we're going to clean up, cover the patient back up. Leaving them neat and clean. Remove our gloves, and anytime you take your gloves off, you want to do glove to glove, skin to skin. Just reverse it, okay? Then that gets thrown away, and you always wash your hands. And you always leave the patient safe. Call bell in reach, side rails up ×2, and you make sure you let the bed all the way back down, okay? Then the documentation, what you would document in the client's chart is your abdominal assessment. And if you think about the way that you did the procedure, that is how you should document. So the first thing we did was assess the abdomen, okay? Then we actually aspirated for residual. Then what did we get back, if we got anything back? Then we're going to talk about what we gave, the type, the amount, and how much of it. Then we're going to talk about the flush afterwards, 30 milliliters of water after. And then you're going to talk about how they tolerated it, and of course all your safety features at the very end. I'll show you documentation in a part 2. Thank you very much.